Hello, everyone. I'm Michael McNutt, VP of Education and Marketing for WEDI, and welcome to Balancing Patient Data Sharing and Privacy, Navigating Interoperability Challenges in Modern Healthcare, a WEDI Health Equity Workgroup event. It's my pleasure to introduce the co-chair for the Health Equity Workgroup from the AMA, Nancy Spector.
Hi, everybody. I want to say welcome as well to our monthly Health Equity Work Group meeting where we've created a special panel today to continue the series that we've started recently looking at uh, SDOH data, personal data, demographic data, and the sharing of that data. So this whole privacy versus interoperability challenge. And just quickly from our work group sort of housekeeping items, uh, I I won't share the agenda on the screen, but I'll just let you know that we are looking to have our scheduled meeting on December 19th at noon. And tentatively, or what we've decided on is for me to do a presentation, something informal, but talking about sort of the language that's used in clinical documentation and coding and how some of that language can be sort of misinterpreted as being derogatory or negative in some way. So it was some information I had put together for something I had done internally with the AMA, and so I'm happy to share that information with everybody. So that's our plan for our December meeting. So with that, I'm just going to go ahead and jump in. We have a great lineup of panelists for our meeting today. Again, talking about the work that they're doing and their perspectives on privacy of patient data. And I am going to let people do a little bit more of an introduction of themselves, the panelists, as they speak, but just want to run through our panelists, our speakers, our expert lineup. Rebekah Angove from the Patient Advocate Foundation, Lesley Berkeyheiser from DirectTrust and co-chair of WEDI's Privacy and Security Workgroup, Tantian Nguyen from Kaiser Permanente and co-chair of WEDI's Privacy and Security Workgroup, Sean Cahill from Fenway Health, and Vanessa Candelora from Point of Care Partners and the Gravity Project. So at this point, I'm going to actually turn over to Janice, who's going to moderate our questions and panelists.
Hi, everyone. This is Janice Karen from the Massachusetts Health Data Consortium, the other co-chair of the Health Equity Workgroup. And I'm going to ask each of our panelists to introduce themselves and tell us a bit about their work related to health equity data and data privacy. And why don't we start with Rebekah?
Hi, everybody. Thank you for having me. My name is Rebekah Angove. I am the EVP of Research and Evaluation at Patient Advocate Foundation. I'm also the Executive Director of our Patient Insight Institute. All of the work that we do here is talking to patients across the country with access and affordability issues and trying to understand their experiences and their perspectives on a diversity of healthcare-related issue related to policy, direct care, and research. And we've actually been doing a lot of work into patients' feelings around SDOH and social need screening, the response that clinics have, and I think most specifically to this conversation, concerns that they may have around how this information is being housed, privacy and confidentiality concerns, how it's being shared. Even beyond healthcare teams, and also some of the stigma and bias that patients feel, not only in just answering the question, but having this being attached to their, informing their care and being attached to their medical records. So we've done a lot of surveys and focus groups and listening sessions with patients. So that's the perspective I'm here today to bring. Thank you for having me.
That sounds great, Rebekah. We look forward to hearing more about that later on in the session. Lesley?
Hi, everybody. Nice to have you all today. I'm Lesley Berkeyheiser. I'm one of the senior assessors at DirectTrust, and also, as Janice mentioned before, one of the co-leaders for the Privacy Security Workgroup here at WEDI. I'm not sure if you all know this, but I actually grew up from a professional perspective working with a few different Medicaid HMOs outside of the Philadelphia area, and spent a lot of time working with special needs and those with social challenges decades ago. And it's taken all this time for our industry to actually crystallize it. And I'm so thrilled to be here today in support of looking at the SDOH challenges and special considerations we have for people having social need issues that we really need to address better in our environment as we do data exchange. From a privacy security perspective, we are struggling, of course, as everybody is, with understanding how the new interoperability is going to be impacting our ability to keep data safe and secure. And I think we'll be sharing and further discussing that. You'll hear one of my big concerns, of course, is ability to trust. Trust both from everybody in the continuum, of course, including, most importantly, our patients. So thank you for inviting me.
Great. We look forward to hearing more about that, Lesley. Tantian?
Yes, good morning, everyone, or good afternoon. Sorry, I'm on the West Coast. I'm one of the leads in the KP Kaiser Permanente Health Information Technology Strategy and Policy Group. Sorry, that's a mouthful there. We're called HITSP for short. Our role is to represent Kaiser on the national front with government leaders, with industry leaders and experts to advocate for KP public policies on a whole host of topics and domains that impact health information technology, or health IT as we call that. So my special focus is actually on security and identity. But we, and then my colleagues are handling other aspects such as privacy, artificial intelligence, interoperability, devices, telehealth, public health, health equity, a whole host of these. And what we get is we may be the expert in specific field, but we don't work in silo. All of these are interconnected, and we need to communicate with each other. So in as much as we represent Kaiser on the national front and externally, we also bring changes, discussion, potential regulation back in-house to discuss with these experts to help shape what the eventual final policy might look like, and also to prepare our organization to become compliant. So I'm really thrilled and honored to be invited to this meeting, and this topic is very germane to all of us, and I look forward to an exciting discussion.
Great, wonderful. Thank you, Tantian. Sean?
Thank you, Janice. I'm Sean Cahill. I'm Director of Health Policy Research at the Fenway Institute at Fenway Community Health Center in Boston. Fenway Health serves everybody. We have about 35,000 patients, but our expertise and our focus is on LGBTQI+ patients. So about half of our patients are LGBTQI+ or sexual and gender minority patients. About 6,000 of our 35,000 patients are transgender and non-binary. We do a lot of sexual health work, HIV and STI prevention and care. We have about 2,300 HIV patients and about 3,500 patients on pre-exposure prophylaxis for HIV prevention. The Fenway Institute is the research, education, and training and policy arm of Fenway Health. And we collectively at Fenway Health have engaged this issue for almost 20 years now, and have kind of looked at the shift from paper to electronic health records as an opportunity to systematically include the collection and use of sexual orientation and gender identity data, which we refer to as SOGI data, to improve the quality of care for sexual and gender minority patients, combine it with race, ethnicity, and other data to engage in population health management, to inform clinical decision support and preventive screenings. Over the last 15 years, approximately, we've engaged federal policymakers, first with the Meaningful Use Program, more recently with promoting interoperability and things like the U.S. Core Data for Interoperability out of ONC to promote inclusion of sexual orientation and gender identity, and try to make it the standard in healthcare to collect and use these data to better provide care to sexual and gender minority patients.
Great. Thank you so much. We're really, really happy to have your perspective here. Vanessa?
Thank you so much, Janice. I'm honored to be on this esteemed group of panelists today. I'm Vanessa Candelora. I'm a senior consultant at Point of Care Partners and the Gravity Project Program Manager. So for those of you less familiar with the Gravity Project, we are an HL7 fire accelerator. Fire is for it's related to interoperability and is really centered around a lot of what you heard from Sean and some of the other panelists just now for the documentation, use, and exchange of data in support of social determinants of health, or SDOH. And so that is what we have been doing over the past 5 or 6 years. We have developed over 20 different social risk areas or domains to identify codes and words that can be used to support documentation and use and exchange of this data, recognizing the extremely valuable importance of doing that in the context of patient consent and privacy. And so we developed a data justice principles and guidelines. Of one of the key pillars is ensuring personal control. And we can talk a little bit more about that as time goes on, but I'm very happy to be here with my Gravity hat on, and also some personal hat related to the way that things have evolved with screening and the increase of capturing data within health equity and social determinants, recognizing holistic person-centered care and what that really means for people and their data and their medical records. So happy to be here. Thank you, Janice and Nancy.
Great. Well, we're really pleased to have all of you with us. And we're going to transition into some questions that we're going to ask the group. And we're going to start with what does the healthcare industry need to do to raise awareness among patients about the sharing of sensitive data? And is there something that WEDI can do to help with this work? And also, if there's anything that you think that patients are particularly concerned about in this area, feel free to raise that as well. And we're going to start with Rebekah.
Oh, I have the last name of A. That means I go first, huh? So there's a number of things. I think the two things that come top of mind for me is healthcare systems don't do a great job of consenting patients about what they're asking, why they're asking, and how they're using it. Even when there's policies and protocols around informed consent and getting written consents, patients are oftentimes rushed through, right? They just sign this thing that they've never read, or they don't need a digital copy now that we're to digital signatures. And within the community that we serve, and we serve patients with access and affordability challenges, there's a big concern that a lot of this demographic and or social need information can absolutely or will absolutely impact the quality or the type of care that they're getting. So there is a concern about why this information is being collected, who's seeing it, what it's being used for. And patients are really concerned about answering honestly because of some of the stigma or how it may impact their care. So those are a few things that are top of mind from the patient community that we serve.
Great. Sean, would you like to comment on anything that's particular, especially in the LGBTQIA plus patients that you serve?
Yeah. So like I said, we've been doing this work for a long time. We started off by doing research on how to ask the questions and what kinds of response options worked best to identify LGBTQ plus patients. What we've said to people over the years is, this is sensitive information. There's a risk in collecting the information and including it in an electronic health record, but we believe that the benefit in terms of improved quality of care and like coupling SOGI information with, say, anatomical inventory and knowing what kinds of screenings to offer a patient, like should you offer a pap test, should you offer different kinds of cancer screenings and other screenings, outweighed the risk. I got to say that with everything happening in the country now, we have seen, we have 26 states that prohibit gender affirming care for minors now. Some of those laws restrict care for adults as well. We've got states that are saying Medicaid will not cover gender affirming care. We've had hundreds of, so 26 states ban the care. We've had hundreds of anti-LGBT pieces of legislation introduced at the state level, a lot of them anti-transgender, hundreds of anti-LGBTQ riders and amendments introduced in Congress in this session alone, and we expect more from the next Congress. We are bracing for anti-transgender policies from the incoming administration and from the next Congress. And so I think it's important to understand that all of this has a negative impact on the health and well-being of LGBTQ plus patients, particularly transgender patients, and their sense of safety and belonging in society. But it also makes people wary about offering this information, having it get into an electronic health record. So I think I want to have a discussion with you all today as experts on privacy about ways that we can, try to ensure people's privacy and strike that balance where it's important information for a provider to know, but at the same time, we don't want to set up a patient for being persecuted because of this aspect of their identity. So that, I think, is increasingly a concern we have with this dramatic rise in anti-transgender politics in particular, and policy, which we saw in the election that just ended a couple of weeks ago, a very central role for anti-transgender politics, very distressingly so.
Yeah, I could definitely see where that's the case. And we'll definitely come back to having a little bit more of that conversation as we move forward and have perhaps some discussion with the privacy folks about that as we move forward. But for now, Vanessa, would you like to comment on what you're hearing, if anything, directly from patients as you go through the data work at the Gravity Project or with other things that you do?
Yes, thank you, Janice. And I'm pleased to hear that we're going to circle back to what Sean's statements just were, because they're so profound and impactful in the ecosystem. And I'll admit my own bias, being in the Boston area, very familiar with Fenway Health. So great work that you're doing there, Sean, and thank you for raising it. I hope I don't take us too far in a different direction here, but to answer the question, I want to comment on one thing, which is we've seen significant legislation around privacy at the state levels, with I think 7 states offering very comprehensive privacy laws being enacted in the last year, which actually mirrors the year before. And so 14 state laws enacted across privacy in the last 2 years, which is very significant. And the word comprehensive, I think, is an important one, because when we think about patient control of their data, which is written into those interoperability laws that the WEDI community and many others are so familiar with coming out of Health and Human Services, CMS, and ASTP ONC over the last few years, that the granularity of a patient's data, I think, is really important. Coming back into my Gravity hat a little bit more, we are one of the only HL7 accelerators that actually has patient representatives, or individual or person representatives, which is really how we think about people that may not necessarily be clinical patients, but individuals that are needing some sort of social support, and sort of bridging the gap between healthcare and social care is a lot of what we do here in Gravity. But we have patient representatives or individual representatives actually at all parts of our project, from our steering committee and operating committees to our work stream working sessions. And so what we hear a lot about is a person's control of their data at a granular level. And with the increase in screening for social needs coming from many different places, including an increase just at the start of this year with some of the incentives with the IPPS rule and others incentivizing clinical settings to do more screenings, we're seeing a lot more questionnaires that are actually, just this morning, personally, I had to fill out a questionnaire in advance of my annual visit that screened me for housing insecurities. And I'll admit, I was not impressed with the way the question was worded and thought I should let them know about Gravity's screening tools and opportunities to ask this question in a nationally standard recognized way and code it accordingly. But I declined because I saw in there that it said, this questionnaire will be added directly to your medical record. And I think that that's a really important thing that patients should be aware of and to read them, right? To Rebekah's point, it's important to read those things. And there's so much information to read that it can be really challenging. But one of the things that has come up specific to patients being in control of their data within the Gravity project most recently is, how do we get from those screenings or screen positives? Hey, there might be a housing insecurity here, or there might be a challenge with financials, or any of the 20 different domains and beyond that we have worked on already in Gravity and will continue to work on. How do we get from those screen positives to a condition or a diagnosis or an ICD-10-CM code, right, that helps us identify the appropriate interventions to support that person? And there's a lot of interest to avoid patients or people slipping through the cracks and having a positive screen, and then whoever is doing that screening doesn't know what to do with it, right? On the clinical side, we're not quite set up for that full to referral process just yet in our ecosystem. And so how do we get from a positive screen to that intervention with a condition with the patient's consent in mind? And so creating automated FHIR structure maps, for those of you that are a little more technical, is something we've talked a lot about in Gravity. And what we've recently heard from our community a few times now, and we're working on a paper to distribute, is the important considerations to put a patient at the center of that information before a housing insecurity, for example, condition gets logged to their medical record. And inferring that from a questionnaire or screening instrument is something that we've talked a lot about putting patients at the center of. And so that's a specific example I can share. Back to you,
So
Janice.
that sounds great. I actually want to take a moment not to interject myself too strongly, but I actually feel like what you were talking about and what Sean were talking about are really tightly tied together. And I know some of the work that I do in my day job at MHGC, we've actually looked at the causes of the insecurity, which is something that people don't talk about so very much. But having the cause of a food insecurity, because it's not always financial. It's not always the things that people care about. A transportation insecurity isn't always because you're so rural, you have to travel somewhere so far to go to places. And so, having the ability to get to the point of having the screenings to actually being able to act in a useful way for the patient is so important in building some of that trust that Sean was talking about. It's something that I hear when I talk to patients, when I've talked to patients or heard them talk. It's not helpful to screen people if you can't do anything for them. And, to go back to Sean's question, I don't know if anyone on the panel would like to interject, perhaps Lesley and Tantian, specifically on the privacy side, but either or anyone else as well, to have that conversation about how we tie together the fact that there maybe should be more direct patient consent than is actually happening right now. And maybe there should be a better understanding of what it means to consent. And then also a better understanding of what happens to your data so that you're not put in a position where maybe you answered something that was really helpful for your healthcare, but it may also put you in a dangerous position later because of the political climate. So I don't know if anyone, it sounds like you might have something you'd like to say about that, Vanessa, but I don't know if anyone, I'm not to put you on the spot, but you're nodding. So, but
I'm just nodding in agreement, Janice. I think it's a really excellent point. Yeah, I didn't know if Sean wanted to comment on that with his population.
Yeah, if anyone on the panel would like to comment further on that.
I can comment, but I can wait too. I can let the other folks speak and then come back to it.
So I know this wasn't directly.
Looks like Tantian is commenting, but I think you're on mute, Tantian. It's okay.
Yes. May I just add some of the thoughts that I have had, and then I'm really interested in Lesley because I always loved listening to Lesley and her sage words. So to me, what I feel is patients are caught in between a rock and a hard place. They show up to the healthcare system because they need medical care services. And they want coordinated care between all the providers to be treated as a person, not as a disease or the symptoms, and which does not enhance the quality of care. So I think they do understand that their data needs to be shared amongst the different providers so that all the provider, whether they're within the system or between different system and standalone provider, it becomes a coordinated care team. So they do understand and they want it. But what they're faced with is, I wholeheartedly agree with you in terms of the patient consent. It is required by each of these provider group before care is rendered. But at the point that you're seeking care, you know what? And to be honest, I'm guilty too. I see words and words, reams of paragraphs. To be honest, I'm just glancing through because I need the care. If I don't sign on the line, I don't get care. So that's called stuck between a rock and a hard place. So, and by that, we don't have full confidence that our data is protected by everyone within that chain of healthcare delivery. Simply because we work in this space, we know a cyber incident, a data breach is a when, not an if. There is no foolproof way to secure a system. So the patient's actually like a fish on the cutting board. You kind of hope and pray your data don't get breached. And to some extent, data breach is so common now. I think people they hear about it and it isn't like, oh my God, the sky is falling down. It's sort of an accepted thing now. So I think there are two things. Number one, patient consent form, given that there are a lot of regulation from federal level in different states. Why is the patient consent form so complex, so hard to read, so legalese? It seems that patient consent form is not for the patient, it's to protect the provider, which we understand, but perhaps there comes a common ground, some balancing thing there, where I think patient consent form, the language needs to be clear, simple, concise, non-legalese, and should be at a common reading level. And let me throw something out there. Why does there need to be hundreds and thousands of different consent forms? We know what a patient consent form is intended to do. Can we come up with a nationally accepted standard consent form that's agreed to most everyone, signed off, and that consent form can be then translated to the drafted at appropriate language that people can understand? Not all of us are reading at university, college, or even high school level. It needs to be available in different format, different languages that the person comfortable to understand that, yes, I know what I'm seeking. I know what I am granting the usage of my data to who, so who, what, where, when, why. Why do you need to receive my data, etc.? So that's one side. The second thing is the technical feasibility. In order to manage the usage of patient data, I think we talk about, at least in Kaiser Permanente, we start to talk about data attribute and data segmentation. Who gets access to patient data? To what degree of the medical record, what kind of data should they? You can't sign off to give somebody all of your records because they only need it for specific purpose. So that's the data segmentation, which relies on how you define the data attribute, who gets access, and who gets to use it. And so that's a technical challenge. I may call it a technological challenge to slice and dice the data points. And I think that requires discussion between the user group, which means the provider, the clinical staff, the administrator, and the patient, discussing with the product developer on the IT side. And the developer, I'm not proposing a solution, but I think this is something we're grappling with. And I'm just throwing it out there and for the panel discussion.
Yeah, you know, I would also add on to that, you know, mixed into that is the idea that once the data is there, there's some legal mandate to exchange it with or without consent, especially on the payer side with the CMS APIs, because it's part of USCDI, which was referenced earlier. And for those, that was what our earlier sessions in this series was about, the fact that some of this is mandated exchange. And before I toss back to Sean, I just want to add that, you know, I just want to add one other perspective and get him to comment on that, as well as whatever he was going to add to this to sum it up before we move on, which is that one of the things that's always struck with me was hearing discussion from some trans patients in a trans health clinic that patients feel like when their data is exchanged without their knowledge, when they tell one provider and they go into other providers and find out that those providers know their gender identity or their sexual orientation and they haven't specifically told that provider, and it's maybe not a provider they trust as much or someone where it's not necessary for the type of care, that they often see it as a form of being outed.
Mhm.
And that's stuck with me. So with that note, I'm going to pass back to Sean to kind of wrap up this part of the conversation with you know, what we'd like to say.
Yeah. So Janice, I think that's a really important example of how it's important for providers and clinical staff to explain to patients what is going to be done with the information. You know, why am I asking you these questions? Why is it relevant to your clinical care? And who else is going to have access to this information? I think that all has to be provided during the consent process before the person answers the gender identity question, you know, and the question is usually current gender identity and sex assigned at birth. But I guess the other things I would say about this is that the word trust has been mentioned, and that's an incredibly important issue in healthcare, as I think you all know. And so with LGBTQI plus patients in particular, and with lots of different intersecting identities, like people of color or immigrants, the issue of cultural competency training is really important. And so when we talk to providers about collecting and using SOGI data, we often use it as kind of a foot in the door to have a broader conversation about how to make your practice affirming and culturally responsive to sexual and gender minority patients. And you do that by training all the staff, including the security staff and the front desk staff, so that they're not necessarily saying like, "Hello, sir," "Hello, ma'am," without knowing how the person identifies. And just little things like that, or putting up a rainbow flag, can really send positive messages of welcoming and things like that. And then in our comments to the Office of the National Coordinator of Health IT, we often talk about how it's important that that information be shared about the purpose of the data collection and how data will be used. So, like, for example, in the early months of COVID, or the early months of the vaccines being available, I think it was one of the big pharmacy chains started asking patients about their sex assigned at birth, but it didn't ask about current gender identity. And so some transgender patients, a lot of transgender patients don't like that question, what is your birth sex? And they find it traumatic to have to answer that question. But it can be, it certainly is a clinically relevant question. But the problem was CVS asked it. They didn't really know why they were asking it. They didn't explain to the patients why they were asking it. And they didn't ask, what is your current gender identity, which is a more affirming thing. And we usually start with that question and then go to, what was your sex at birth? So that's an example. So it has to be explained why you're asking the questions, what you're going to do with the information, and patients should be clearly informed that they have the right to ask the provider and the healthcare practice not to exchange their SOGI information.
Great. Thank you. And I would again note that it should be made clear to patients that once a payer has it, particularly if they're in some of these particular plans, the payer is legally obligated to share it starting in 2026. So that should be something that is made clear to patients as well. Lesley, I'm going to pass to you for any thoughts that you have on this question, as well as, since it's kind of come up here a bit, do you think sort of addressing the current regulations and some of what I've alluded to or other regulations provide enough patient control over sensitive health equity data? And if not, do you have any thoughts on how we might be able to change it? But feel free to sort of combine that with an answer to or a comment on this discussion as well.
Awesome. Where to begin? There have been so many things, and I've been keeping notes saying, I want to respond to that. I want to respond to that. I think we could all go on for a very long time with very important things to talk about. One of the most important things I wanted to come back, Sean, when you were first talking about everything everyone is experiencing now, I was immediately also thinking about all of our changes in reproductive health, just being right alongside all that. And I saw someone else in the chat also felt the same way. Often across WEDI, the Privacy Security Workgroup often feels like the kitchen sink. I think you guys are the new kitchen sink. We have all kinds of issues and they can fit in what you do. So let me go straight to, I wanted to comment first on the first question and the concept of patience and trust, because one of the things that we've already identified in our Privacy Security Workgroup, and we're trying to figure out how to help the industry, is that patients, especially thinking about the ability to get data on mobile apps, understanding that not everybody has mobile apps, but many of our current people do. And when we are doing other things like banking or shopping or anything else, we're using these APIs, whether we know it or not. And we're used to having quick questions and things to respond to on our phone. So we are expecting that once we start seeing the patient access rule actually become implemented, and I know it should be, we just don't feel like we're seeing a lot of it yet across our industry. Our patients are going to be really confused about what apps they can trust. And so one of the things we've identified is some way to help teach patients, providers, payers across the board when an app is vetted, if you will. And this goes into, for example, and I know our friends at the Gravity Project and those as an accelerator, you're familiar with the UDAP, the Unified Data Access Profiles. For example, I understand that the current use of the UDAP, which are dynamic registration authentication assistance, if you will, for those of you not technical, which is part of the identification and authentication process. When I go to use my phone to begin the process of asking for my records, that two things. One is a green lock, for example, should show, just like we all used to get used to seeing a good housekeeping seal decades ago, so that there's some way for the doctor to talk to the patient about when you see this green lock, for example, or you see this name. We see it now with VeriSign, or have for a long time when we go to do things. When you see this, whatever XYZ is, you know it's been through an independent review by people that have given it credibility or say that it's more trustworthy than others who don't have it. Some easy way to teach our doctors and all those who care for our patients and our patients when they can trust using this new capability that's going to hit them across interoperability. And I know that's kind of future thinking, because I'm right with all you all as a patient. I still struggle just trying to get somebody to give me my records and trying to get a copy. And I can't imagine saying, I want it right now on my phone. Give it to me. Tell me how to get it on my phone. I can't get them to answer just normal ways most of the time. So I realize we're all struggling. So number one, a way for patients to be able to know they can trust the apps. We think that's huge. We're trying to figure out what can be done about that and how we can help the industry. And I think it's an area that our work groups could really work together on. The second thing that's related to that, and I'll go back to our Gravity Project friends, The unified data access profiles, it was my understanding that they kind of add another, I'm just going to call it a layer for non-technical people, of wrapping the actual data as it's moving along. And within it, I know the initial early work included additional, I'm going to call them fields or ways that specific patient consent or specific data or specific requests could be built into the actual data as it moves along the continuum. You're shaking your head on that. Can you confirm that's still in place and still our goal? It's just we haven't gotten there yet, right?
Yeah, so one of my other hats, non-gravity, is in DaVinci, which is another HL7 Fire Accelerator, and then of course the FAST, the Fire at Scale Task Force. So what you're describing is really use of the FIRE standard for exchanging information about patient consent, and that is very much still in place. I think there's a consent a work group or use case within FAST. That kind of runs that work, Lesley. So you're right on, and absolutely, I think something that people should take a closer look at, see what else is happening within the ecosystem, and really lean into as an opportunity to exchange that data in a standard, meaningful way.
Awesome. So I'm thinking, Janice, those are 2 action items that we all could work on together. 1, trying to figure out how to teach the patients they can trust, and 2, trying to figure out how this data could move around in a more secure way and allow for an additional level, if you will, of privacy control baked in.
That sounds like a good idea, and we definitely should talk about that further. Vanessa, your name's been invoked several times here, and although I know that you expressed agreement to a lot of what was just said, you didn't particularly chime in, which is totally fine. But I thought it might make sense for you to go ahead and maybe talk a little bit about how the Gravity Project specifically considers patient consent or privacy issues or concerns when you're working on new standards or new implementation guides or new use cases within SGOH.
Sure, Janice, and I hope I've been transparent in my responses to questions. So if I missed something, please ask it again so I can ensure that I either address it directly or get back to the group. I apologize if I'm
Oh no,
not
it
answering
was
them
open
directly.
to anyone. It wasn't,
Okay.
you weren't required to answer that. I just thought that it might make sense to do that.
For this question, I'm happy to. So I mentioned in my original introduction that one of the first things that Gravity did early on, so we started in 2017. I'm looking at version 3 from August 2020, and I'm happy to drop the link into the chat to our principles of data exchange for equitable health and social care. And so the consensus of this, it's not long, it's only a couple pages long, really talking about our social justice principles. But one of the key pillars of this document is ensuring personal control. And so the exchange and use of personal information should account for the diverse needs of all stakeholders without erecting barriers or diminishing function or quality for those with differing abilities, languages, or cultural contexts. And patients should have ready and complete electronic access to data about themselves wherever these are created and maintained, as well as tools and educational resources in their primary or preferred languages to make meaningful use of that information. Each individual has the right to consent to and challenge the collection, content, retention, use, or disclosure of information related to them, including the right to have the particular information corrected or admitted. Now, that is a lot easier said than done, as we all know. Once something becomes part of a medical record and it gets proliferated to systems, trying to change it can be a very challenging step, particularly for a patient who's navigating a complex system. And so I read it slowly, purposefully, because I think it's important to recognize. And we made the genesis of this document is really to say, if you are venturing into any sort of whether it's IG development and standards, or it's an implementation project where you're using standards, or even not, it is always important to have health equity at the beginning, the middle, and the end of a technology project specifically, because understanding what the impact is of applying the technology that we absolutely need, and the automation where it makes sense to have in order to improve our system and overall health and care is a really important piece. Thank you.
Great. I'm going to pass things back to Nancy now to open up for about 10 minutes of audience questions, either taken from the chat or if people want to raise their hand and ask something live. And then at the very end, we'll come back and let everyone have a really quick final word. And this has been so awesome that we may try to do part 2 at some point in the future. But Nancy, go ahead and open things up.
This has been such an interesting conversation, and I've been trying to keep up with everything in the chat. I believe that a lot of what's here are comments, or if it was a specific question, that panelist has jumped in and provided a response. But if I'm missing a question, please raise your hand, and we will definitely address it. I was just thinking that hearing all this, and definitely Vanessa, what you were just talking about there with principals, I think that it would be helpful for us, the work group, to put together a even if it's just a simple sort of resource page where maybe we can have the links that could point people to these different resources, documents, and just get something out there that can generate knowledge. We certainly don't want to try to reinvent the wheel on any of this stuff, but getting people to awareness around what's out there and what it is, and then they can look to how they can incorporate that. Okay, so just looking here. Oh, Vanessa, you just put links to the gravity data principles. Okay, so one comment here. A big part of the problem seems to be that EHR vendors have not built in the capability to record/implement patient preferences for data sharing or not sharing. Does anybody have sort of thoughts around that point? Sean, is that since you're in a an active clinical workspace, is this something that with your, I'm assuming, EHR system, and is there any engagement you've had with your vendor on any of this?
I haven't. I'm more on the policy side than the clinical side, but one thing that we have asked in our comments to ONC on the U.S. Core Data for Interoperability, one of the comments we submitted last year said, we support the inclusion of consent affordances for patients during instances of health information exchange and exchange of patient data. We believe that patients should be able to opt in for data sharing of sensitive information, including sexual orientation, gender identity, and sex characteristics data, which is data about intersex patients. So we're broadening that acronym to SOGISC. But we've heard that that's actually not something that ONC could do. But I know that in 2015, it was through the Meaningful Use Stage 3 guidelines that the federal government said to EHR software developers, you have to have fields. If you want to be a certified EHR technology, you need to have fields for SOGI. There wasn't a mandate to collect SOGI data, but there was a mandate that the certified EHR technology have the fields. So I think that the federal government could say that about opt-in or something related to sharing of data. But if it's not ONC and CMS, it may be another federal agency, or it may be something that just has to become a practice within the private sector, that we have to advocate with private companies, the big ones that kind of set the standard for the field,
Okay. And Tatiana, since you're at Kaiser, do you have any experience or understanding of, what's your EHR system is doing this?
I would have to take a pass on that, Nancy, because
Okay.
I'm more on the
Didn't mean to put you on the on the
No,
spot.
not at all. I'm more on the policy side, but there are
Okay.
certain people who are
Yeah.
working directly with our EHR vendor.
I think,
Well,
I've done a little, I don't work in a clinic, but I've done a lot of work around some of this clinical kind of screening and privacy issues. And we've actually worked with some big EHR vendors trying to adapt or modify some of these platforms. And they weren't originally built for these purposes. They were originally built for, ease of billing. And I think that's one of the challenges, that these add-ons, they keep building onto the EHRs, but it's still a platform that wasn't originally built for some of these kind of big data sharing, kind of the co-creation with patients. And the other side of this is now with the inclusion of the Z codes. If we think about patients being able to have some influence and, editorial power over what's in their EHR, once those Z codes are in there, I mean, those are in there for, diagnosis and billing. And then the challenge is some of those Z codes themselves actually have some pretty triggering and biasing, stigmatizing language in them themselves. So it's probably a whole nother can of worms, but it's an interesting component when you think about adding in those Z codes to this whole kind of conversation that we're having.
Which leads us right to Nancy's topic for next month. So that's excellent. I actually would like to chime in slightly on this topic, if I may, because I find it really interesting that we have been talking about pretty granular levels of consent here, because one of the things that I've found is that most systems currently don't support real patient consent to the extent that we're used to when we used to all use paper forms. And that's why a lot of consent still happens with paper forms at the moment, because you can write in, this date to that date, only these types of services, only this doctor. And a lot of the stuff that's happening electronically is at a very high level of all or nothing. And there's some segmentation going on, but that's still at a pretty high level. It's one step down from all or nothing, but someone else is still deciding for the patient. This is the stuff that we're grouping together in this segment. And you can consent to or not consent to this segment of stuff. And until we get to a point where there's actual real granular consent built into the system, this is going to remain a real issue from a patient perspective, because what's sensitive for one patient isn't the same thing that's sensitive for another. And yes, we can make generalizations or know that for the average patient, whatever that actually means, these groups of things are the things that they're most likely to feel are sensitive or not want to share, or perhaps subject to sharing. But, for someone who's disabled, it may be certain medical records that are related to their disability that don't qualify as, demographic data that's often segmented, or even directly SGOH data. But that's still really in the same bucket of stuff. But even within this stuff, some people are going to be sensitive to A, B, or C. And the other thing that I want to point out is that even at this level, we're not always collecting data at a level. The data itself may not be granular enough to be helpful for these purposes. What does it mean to be of a certain religion? Is it the religion that you practice? Is it your genetic depending on where you are in healthcare, it may be what type of clergy you need if you're an inpatient, but it may also be what screenings you need if you have an ethno-religion that has a genetic component. It may be related to your diet if you're seeing a nutritionist. And so I feel like this entire conversation has so many layers that we're just really at the very top of. And I think it's really important that we dig in. And so the segmentation, I know that we're really focused on the the consent and the privacy and the segmentation, it's all tied together. But someone was saying earlier on, it's not one thing. We can't really separate out, I think it might have been Tantien, we can't really separate out the security or the privacy or the data from everything else. And this is an example of where I feel like that's true. And I apologize, I didn't mean to sort of get up on my high horse about that. But we all have strong opinions in these areas. And There's about 5 minutes left, so maybe we should give everyone else if there are no other audience questions, give folks a chance to have a final comment.
Yeah, I think the conversations going on in the chat are being asked and answered as comments are being made. So yes, we could just take a couple minutes and let each of the panelists give a last word. So I'll just start with who I'm seeing on screen. So Tantien, do you want to kick us off?
I really don't have a last word because this is just the beginning of the discussion and the journey. And I think it involves a lot more people outside of this group. And in fact, I actually am thrilled with this because, in my world of quote unquote security, I get to work with security and privacy because there is interconnection. And now added to that interoperability, AI, health equity, we're all in an ecosystem. And when there is something that's getting done to benefit one quote unquote domain, there is that ripple effect across others. And so I'm looking forward to more collaboration on this.
Great, great. Rebekah, I'll call on you next.
Yeah, no, I appreciate being in this group because we talk to patients all day, every day, and I think it just helps center that patient experience is so important. We can build things that work for the clinic. We can build things that work for our policymakers and for our, statisticians and all of our technical people. But at the end of the day, if the process, the questions, how it's being stored, any of it, erodes trust or is stigmatizing to patients, I think we've missed the mark. So continuing to think about not just patient-centeredness, but like patient experience first is critical to making sure that we're serving everybody as we're building these, making these decisions around technology. So thank you for having me here.
Great, and thank you. Sean, you're next on my screen.
I'd just like to say thank you. I hope this is the beginning of a conversation. We can continue this because I'd really love to tap into your knowledge and expertise to help us figure this out. The only other thing I would say is that when we train people in how to collect and use these data with adolescents, it's sensitive, and so sometimes what we say is, if the adolescent is not if they're not out to their parent and fine with their parent having this information about them, they can tell a trusted provider, but the provider doesn't have to put that in the EHR. And so maybe with adults in a state like Texas, where there's some really draconian laws in place now, and where transgender people are very, very, in particular, very worried about the potential, the potential of having this information in their EHR. If they have a trusted provider, the provider can know that they're transgender and provide appropriate care without putting the info into their EHR. The problem is to bill for a lot of the treatments, like hormone therapy. It's a treatment for gender dysphoria. So you'd have to have that in the EHR somewhere to be able to get reimbursed through insurance. So that's one of the tricky things about it that we're grappling with,
Great. Lesley.
A couple quick things. Thank you. One is the importance of trust. Back to what Sean was saying, I'd like to take us next time discussing value-based care and our safety net providers and whether or not they're actually getting appropriately compensated for taking care of people with needs, specific needs like this. And last, don't forget the Privacy Security Workgroup is hosting Director Noonan December 11, talking about reproductive health. Oh, looks like Michael put the slide up for us. So thank you for that plug.
Perfect.
And I don't want to take anybody more time. I know you have a few more people to get through.
Vanessa, you're actually last.
I am. I think we're perfectly timed, Nancy. You did an excellent job. Thank you so much to you and to WEDI for having us today. I'll echo what Tantien and Sean and others have said, that I hope this is the first conversation of many. And, I think leveraging the consensus and community collaborations that are just so important to bring us together to really get it right and build that trust that's really been a theme of this panel is essential to us progressing forward for whole health, person-centered health. So thank you so much again, and appreciate it. And it was great to be on a panel with all of you.
And I just want to say one last thank you to the panelists. You guys have been great. This has been really interesting conversation. We will definitely be emailing you probably in the next 5 minutes to set up a time for us to do part 2 of this discussion and take us in some other directions with this. It looks like there's no shortage of things for us to talk about in this area. So again, just want to thank you and look forward to having those of you who attended today's call join us on our future Health Equity Workgroup calls. And thanks everybody and have a good day.
And December 19th at noon is our next session. Thank you, everyone.